Hi, my name is Matt. I'll be a floor nurse.
I'm Megan in Tucson, and I'm going to be a nurse manager.
I'm Megan from Phoenix, and I am the charge nurse.
Good evening, I'm Marlena, and I'm the case manager. So today we are here to discuss readmits of CHF and recommended home-based programs for monitoring their symptoms. So as of right now, standard care is being offered at Desert Regional Hospital. This includes the use of medications such as diuretics, beta blockers, and vasodilators. The patient is encouraged to track their disease through things like daily weights and other symptoms like shortness of breath, fatigue, nausea, or loss of appetite, according to Foster 2014, tracking symptoms of heart failure on the Health Library site for Desert Regional Hospital. Telehealth or remote monitoring should be added to the patient's plan of care. Inglis, Conway, Cleveland, and Clark 2014 found that compared with usual care, structured telephone support reduced the risk of hospitalization due to heart failure in a meta-analysis study with a mean participant age over 70. In their study entitled, "Is Age a Factor in the Success or Failure of Remote Monitoring in Heart Failure, Telemonitoring and Structured Telephone Support in the Elderly Heart Failure Patients?" Inglis, Conway, Cleveland, and Clark 2014 also noted that there were high rates of adherence to remote monitoring for heart failure in those over the age of 65. However, they did note that 3% of the participants could not fully use the monitoring completely. This could be due to the fact that they didn't understand how to use the technology. If this is part of the patient care, then the nursing staff needs to be rehearsed in the technology, therefore they may educate the patients upon discharge. We as a committee can go even further as to implement classes on how to use the telemonitoring system, just as if the patient had to go through pre-operative classes. This way the patient can hear and see the information or if there are questions that the patient needs answered quickly.
So yeah, I agree with your idea about implementing classes to teach the patients on how to use the telemonitoring system. According to the Desert Regional Medical Center website, classes are offered to a variety of patients depending on their particular condition, but according to the same website, the only classes available for patients needing heart care is a support group that delivers information the first Wednesday of every month. More classes should be offered to patients that actually educate the patient on how to manage their disease at home. Even if the patient is encouraged to track their weight daily and other common symptoms associated with heart failure, it doesn't necessarily mean the patient's going to comply. As Marlena mentioned, telehealth monitoring could be extremely beneficial for these patients. If the patient is able to be monitored remotely, it might increase their motivation to maintain a healthy lifestyle. In a study published in the Journal of Telemedicine and Telecare titled Telehealth on Heart Failure Results of the RECAP Project in 2015, they sought to determine what is needed when developing a telehealth program. So Varon, Lowe, Minter, Stapleton, Thompson, Jackson, Roca evaluated 2 different monitoring systems. One of the systems offered the patients more educational information through a personal healthcare television channel, and the other offered more mobility to patients. The authors actually found a general improvement in patient compliance when they used one of the telehealth options. I agree that offering classes to the patients and encouraging a telehealth monitoring system could be beneficial and improve the patient's management of the disease at home.
Right, and I'm sure patients will have concerns about their privacy and HIPAA. So to ensure that health records are secured, safeguards will need to be established according to Anderson and Frith, privacy, security, and confidentiality. In Alexander and Frith, applied clinical informatics for the nurses, this includes access control, audit controls, integrity, entry authorization and transmission security. Hardware will need to be installed to monitor the staff's action within the system. At the hospital I'm currently at, the staff needs to log in multiple times to access the chart or even the internet. Their badges do allow them to access to the computers just to log on, but they still have to put in their domain, their username, and password manually to access the EHR. Each desk item that is chosen also requires as well. It is added protection that we need to add to ensure the patient's information is secured and that the staff is not going to websites they shouldn't. Audits should happen frequently to make sure that there isn't a breach or misuse of the system. I do think it will help promote the staff to keep the patient information private and confidentiality. Do you guys have any other suggestions that might help secure the patient's medical records?
I do agree with the points that you first brought up, but as far as the ethics of accessing the EHR, that is a little bit more tricky and something that I'd like to talk about a little bit more. These nurses have a social contract with our patients that we will maintain a patient's privacy and confidentiality. The information that we are accessing in the EHR definitely fits under the category of PHI, or Protected Health Information, which is individually identifiable health information. According to Anderson and Fripp, 3 criteria are used to qualify as PHI. Information that can identify the patient, like names or addresses, past, current, and future information about the patient's physical and mental condition, and information about the provision of care. According to the HSS.gov website's summary of the HIPAA privacy rule, the privacy rule of 2003 stipulates certain reasons we can access the EHR, and applies to covered entities like our hospital. Even though we are HCPs who routinely access patient records and will be reviewing hundreds of patient records in this case, the scope of this access is a significant difference from normal treatment. The privacy rule is in place to protect patient information, but has an exception if we are actively going to treat a patient. We do not need authorization in that case. But we are selecting only certain patients to treat with the nanochips, and withholding treatment from those we feel are at less risk of hospital readmission, and in some cases excluding certain patients from treatment. This doesn't sit well for me. Not only are we accessing hundreds of records, which would be fine when we're actively trying to prevent a disease or the worsening of a condition, but we are denying a treatment that could be beneficial to some patients based solely on the criteria of readmission, which is more of a financial reason. Does anyone else think that this poses an ethical dilemma? Those patients that we exclude might want to be included as well. Don't they have a right to the same benefits that the nanochips provide, despite not being admitted to the hospital as much?
Yeah, I totally agree with you, Matt. It's not fair to only offer nanochip technology to a certain patient population when other patients could benefit from the same technology. CHF patients aren't the only patients that have a high frequency of being readmitted within 30 days. Nanochip technology could benefit not only CHF patients, but also patients that have COPD or chronic kidney disease or any other condition. It's important to take these patients into consideration as well. However, this is the first time nanochip technology is being offered, so we don't know how it will impact patient readmission rates. It might not be a good idea to invest all of this time and money by offering nanochips to every patient when we aren't even sure what the results will be. Daggers, McCaskey, Brazelton, and Kennedy published an article in 2008 that talk about the upcoming potential of nanochip use and how it can impact patient management of chronic diseases. The authors state that most of the available nanomaterial-based products aren't even used in healthcare right now, but many products are starting to emerge for use in healthcare. But that's just it. There's so much that we can do with nanotechnology, but a lot of it hasn't actually been tested on patients. There's so much that we are unsure of when it comes to nanochip use to improve patient self-management and reduction of readmission rates. Why would we invest all this time and money by offering this option to every patient when we aren't sure of the results yet? It might be a good idea to start by trialing the use of nanochips at home for any patient admitted with CHF, and then depending on the results after 30 days, expanding the option of nanochip technology to patients admitted with other common problems.
That sounds like a great idea to deal with that uncertainty about whether the nanochips are effective. It would be like a clinical trial to evaluate the use of the nanochips and their efficacy in preventing hospital readmissions. It just seems ethically unsound to offer the devices to a target patient set that simply cost the hospital the most. All patients admitted to our hospitals deserve the very best treatment.
I also agree with what you're saying, Matt. This poses an ethical dilemma because every patient has the right to receive treatment no matter what their prognosis is. I feel as though if we were to use the nanochip monitoring, we would have to offer this program to all CHF patients in order to maintain the ethical code. There is also other ethical issues that need to be addressed. Alexander et al. 2015 states that HIPAA allows the patients to authorize information that can be shared with specific individuals. By the patient giving permission to accept using the nanochip at home, we're still maintaining their privacy and security. The only issue is making sure that the monitoring of the patient will only reveal the relevant information needed to decrease their readmission chance. There are still ongoing issues with patients giving permission to access their personal information, but then nurses or other individuals having access to health information that is irrelevant to their current condition. We must ensure that the nanochip strictly monitors those particular vitals and is only applied to their condition of CHF. It could become a potential problem if we are monitoring patients from home and applying their information we receive from the nanochip to use towards a different medical condition that the patient has that is irrelevant. The U.S. Department of Health and Human Services also states, as part of the privacy rule, there is a principle of minimum necessary. This means that the minimum amount of health information should be used in order to achieve the intended purpose. How would we make sure that this monitoring is only used for the purpose of CHF treatment and not other medical conditions? We could run into the same issue as we brought up earlier, that by doctors withholding complete treatment for a different medical condition because of the information they access from the nanochip.
I agree with you, Megan. Only the information that is pertinent to the treatment of the patient's diagnosis of CHF should be used with the nanochip. I also wonder about security. I think that securing the data at our site and within the EHR is not too much of an issue because of the points that Marlena brought up. What concerns me the most is the transmission of the data from the nanochip to our secure servers. Is this technology like mHealth systems that we're accustomed to? What level of privacy will our system provide in the transference of patient data? According to Milosevic, Johanna, and Milankovic, issues of privacy and confidentiality are addressed and protected by HIPAA and updated by the 2009 HITECH Act. These authors explain the technologies that fit into mHealth technology and must adhere to the regulations in place. As mentioned by Simpson, the financial industry has already had problematic issues with securing data in transit. That's like the Target case incident with credit cards. According to Anderson and Fripp, we should perform a risk analysis of the system, appoint a security officer, and develop policies and procedures for the data that we collect from the devices to ensure their security.
I agree. Patients will be concerned about their data being breached and will have to rely on the staff to self-report if any part of the Privacy Act was violated. There are policies in place, but we should consult with our IT team to make sure the firewalls and other technical safeguards are constantly updated. We can also run audits and conduct yearly HIPAA training and reviews for the employees. Patients can also sign a privacy notice saying they don't want information passed without their consent or solicitation like follow-up surveys and whatnot.
Yeah, that's a really good idea. I like the idea of yearly HIPAA training and reviews for employees. Even though employees are trained on HIPAA when they get hired, it's easy to forget the details. As Anderson and Fritz state, the challenge is remaining aware of the need for privacy and following the policies in place. It's easy when nurses and other healthcare providers get into their daily routine to forget to follow all of the HIPAA guidelines. It would be good to make sure employees have a review every year.
I completely agree. And in addressing the ethical considerations, I think a much sounder ethical way of dealing with the problem is, if in the process of admitting a patient, we gain informed consent and offer the nanochip monitoring. We draw out the criteria of whether a patient has been readmitted to the hospital within the past 30 days. This adheres to a more ethical form of treatment because it holds true to the ethical tenets presented by the 4 pillars of medical ethics, as described by the University of Ottawa's website, Basic Ethical Principles. By gaining an informed consent from patients, we are respecting a patient's right to autonomy and privacy, which allows us to use the use of the EHR to see if they are a worthy candidate for treatment in the first place. Patients have a right to know the risks and benefits provided by the nanochip technology, which adheres to the principles of non-maleficence, or doing no harm. By offering all the patients the nanochip, you would be addressing the key issue of justice. According to the University of Ottawa, the principle of justice states that in allocating resources and care, patients in similar circumstances should have access to the same kinds of care. I believe that having chronic heart failure is the similar condition. Being readmitted to the hospital within 30 days is an artificial criteria. That should be dropped, especially when any patient with CHF or receives the nanochip could benefit from increased monitoring of the condition.
I agree with what you're saying, Matt. Sometimes hospitals will use certain criteria to try to predict when patients and if patients will be readmitted to the hospital within 30 days, which doesn't display very accurate or reliable results. In one particular study, researchers used a tool called the LACE index to predict hospital readmission in patients with CHF, from Wang et al. 2012. The LACE index was based off using hospital databases to calculate a score which combined certain factors off the patient to predict their readmission chance. The researchers found that this method was not reliable and could not predict unplanned readmissions within 30 days. By gaining a person's informed consent, like you said, to use the nanochip at home, we are not violating their privacy and we can still maintain confidentiality.
Yeah, I also agree that every patient must have been thoroughly educated on the potential benefits and risks of nanochips and has given us informed consent. We shouldn't access the EHR of patients that haven't given us informed consent. We also have to make sure that the only people accessing the EHR are the healthcare professionals that the patient has consented to and that are involved with the nanochip implementation, or they're directly caring for the patient. Simpson published an article in 2006 that talks about ethics and information technology. And basically what it boils down to is that as nurses, we are in a position to ensure that ethics are followed and to use information technology to positively impact patients. Along with using the EHR to access information for patients that will be receiving the nanochips, there's also other ways to decrease the risk of readmission. As nurses, educating our patients prior to discharge is one of our main tasks. Nurses are constantly educating their patients throughout their shift. One thing I've noticed on the units, though, is that the nurses get so busy they don't really spend the time with their patients to ensure their patient truly understands the discharge teaching. If the nurse were to sit down with the patient and really go over the discharge teaching and receive a return demonstration to make sure the patient's understanding what they're teaching them, then that could also reduce readmission rates. There's so many educational materials that nurses are able to print that apply to their patients, and all of them that apply to that particular patient should be utilized.
Right. So our plan seems like it'll be using the nanochip technology, education, and other telehealth monitoring, like a phone line, along with the standard care. Nurses will be the primary educators on discharge for the standard methods and the technology to use to help monitor from a distance. We will add more classes as another tool to help educate the patients on the new technology being implemented. I think these classes should be required if they decide to take part in this program. As Megan from Tucson has stated, the nurses don't spend the time as they need to on the discharge explaining the information. The elderly population will most likely have the biggest learning curve, and the classes could help answer any remaining questions they might have. Rating them on a scale to help set up a better patient-specific plan and to see if they meet the eligibility of the telehealth program should also be considered. Matt brought up an important point of the informed consent. The patient needs to be aware that the telehealth will, what the telehealth will require, and that they have the option to back out at any point in time. We will come back in 30 days, check the status of readmissions in the CHF population, and report our findings. So thanks, guys.
Good.
Thank you.
Bye.
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 Bye.